will find the ST down and the T wave inverted. Same issue with any patient, any lead with a negative complex, you will find the ST elevated and the T wave is upright. So in the opposite direction, and we call it discordant. You see, discordant. So it is a normal, and in presence of this depression or presence of this elevation, it's really hard to tell it is an MI or not, isn't it? Because elevation is there anyway. And if you can go back to the ECG, you will find here an ST segment elevation, isn't it? Elevation, more or less. Depression, 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 which is confusing us, isn't it? So, but it's normal. If it is in the opposite direction of the QRS complex, it is what left bundle looks like. Okay. What's Sgarbosa criteria? There are only 3 criteria and they are simple. The previous slide shows that the elevation or the ST deviation is in the opposite direction of the complex. But if it is going with the same direction of complex, it is abnormal for left bundle. Is that right? So, concordant means in the same direction. ST elevation more than 1 millimeter and leads with a positive QRS. So if there's a positive QRS, I expect the ST to be down. But unfortunately, it is up. So it is abnormal. You got it? Second one, if there is depression of more than 1 millimeter, which is small square, 1 small square, and V1 and V3, usually V1 and V2 and V3, they are having a negative complex. You remember the previous ECG, they are negative complex. But if you find a depression with a negative complex, it means they are going in the same direction, which is abnormal, supposed to be elevated. Do you understand? Mm-hmm. Okay, these 2 statements are easy to pick up because it is against the normal phenomena. It means negative, I expect negative complex, I expect elevation, but instead I found depression. Complex is positive, I expect depression, but I can find elevation. Easy to pick up. But excessive discordant ST elevation, it means normal left bundle, but excessive one. So negative complex ST elevation is there as normal, but the elevation is really extensive than expected. So they define as more than 5 small square or 1 big square elevation, followed a negative QRS can define a presence of MI. So excessive discordant ST elevation more than 5 millimeter and leads with a negative QRS complex. It is another criteria. Have you got it? It's simple. I'll show you. Again here, same. I'm going to re-explain again, but in a real one. Usually, if I have a positive complex, I expect negative ST and the negative T wave. But here, it is not negative, it is going positive together with the complex. Isn't it easy? In that one, like V1, V2, V3, it is negative. I expect elevation same way, but it is coming down, so it is abnormal for left bundle. In V1, V2, V3, usually we find a negative complex with elevation, but if it is more than 5 small square, it is significant. But less than 5 small square, we consider it normal because of left bundle usually have a significant elevation if in this picture. Is that clear? Does it make sense? Okay. Here one point they needed to discuss about the subjective assessment. What I need to tell them, if I have a low amplitude ECG because of emphysema, because whatever, I have discussed the low amplitude before, I expect the complex to be small and the elevation will be low and everything is low. And on the other hand, if the voltage is high because of ventricular hypertrophy, because of whatever, so I expect it will be longer and the elevation will be longer, isn't it? So there is some subjective judgment or some clues can actually confuse us, isn't it? You got the point. So they try to modify the Sgarbosa criteria to cover this defect. So they make it as a percentage of the complex to accommodate the variation in voltages. You got it? I'm going to discuss it after 2 slides. It's just quick because that was there and I need to utilize it. This some ECG changes for left bundle was posted as Sgarbosa. Usually, if you can see to AVL, usually expect ST depression in AVL with T-wave inversion, but here it is elevated. You can see it.
Yes.
Okay. Can you see the depression?
Mm-hmm.
This is positive and this is depressed. Can you see it?
Yes.
Okay. Can you see that? E3 with negative complex, I expect a positive ST and positive T wave, and it is not there if you have the same. Is it okay? Another one. Is more clear. What's that? Is
The
left
base
bundle?
rhythm.
It is basing rhythm. Just same rules applies. Same rules applies. Basing rhythm and left bundle branch block. You can see the complex is down and the ST is down as well. Usually in V1 we find you find it down but up right ST and T wave. Same way here. Depressed ST going in the same direction of the complex. Is that clear? Okay. Okay, what's this? Someone to pick up any abnormality.
V5, V6 has RSR.
Yeah, it is left bundle.
Yeah.
So RSR and
Yeah.
ST depressed is normal for left
Yeah.
bundle.
Yeah.
So it is left bundle defined. Yeah. So what points we can spot here regarding Sgarbosa criteria?
V2, if we see the
V2 elevation, but is it
Yeah.
more than 5 square?
I don't think so.
If it is in the opposite direction of the complex, we count how many small square. If it is
Yes.
more than 5, so it is recommended as
Significant.
abnormal. Can you see it 3 and AVF?
Yes.
It is the ST is elevated and it is the same direction of the complex. Same way in VF. So it is an inferior involvement
Okay.
to some extent in D2.
Need to, yeah.
So it is again positive for MI. Okay. The way to find one, as I told you earlier, it is a bit subjective in V1, V2, V3 about the 5 small square elevation because it is supposed to be interpreted in the context with the whole voltage rather than a specific criteria for its own. So the use of 5 millimeter cutoff for excessive discordant was arbitrary and non-specific. In fact, for example, patients with left bundle and large voltage will commonly have ST segment deviation more than 5, which is normal because he has a big voltage or large voltage. In the absence of ischemia, the modified rule is positive for STEMI if there is discordant ST elevation with amplitude more than 25% of the depth of the preceding S wave. Not the whole complex, only the S wave. What is the length? 25% of it. It is the normal variation of the ST segment elevation. If it is more than 25% of that S wave, it is abnormal. So it is a bit managed the area of subjective judgment. Is that okay? So the criteria, I'm not going to repeat all of them because they are the same. I'm just going excessive discordant ST elevation, more than 25%, but other criteria are the same. It's only the V1, V2, V3 issues. Okay. Some other criteria are there to define a left bundle was MI, but I'm not going to discuss anymore now. Later on. This is enough. This knowledge is more than enough. Okay? So the next to discuss is the breast ST segment. I have covered all the ST segment elevation in previous sessions, and now we're going to discuss about the breast ST segment and what will be the causes of ST segment depression. Sorry. Of course, ischemia could be, but the criteria of ST segment depression and ischemia is important. It is either horizontal or down sloping. I will choose a difference. So ST segment either horizontal, depressed, or down sloping. Because, why I'm telling that, because in tachycardia, it could be depressed as a demand because the heart is working so fast. So a demand of oxygen, so ST segment went down, but it is up sloping. So it goes up. In digitalis effect, it has a characteristic features I'll show to you, which like a sagging or coving, and strain pattern for left ventricular hypertrophy. I have covered it in LVH session, but I'm going to show it to you again. So, can you see the depression over here?
Yes.
It's going down. It's depression, but going down. Can you see it? This is how the ST segment depression looks like in ischemia. And of course, we can define this V2, V3, V4, V5, V6. They are all depressed and they are all the same pattern. Okay. What's this? Digoxin. It is unique feature. Can come with hypokalemia as well, but it's more common. I believe a couple of days back we had an ECG similar to this. Has been seen by Dr. Kona, and he was trying to contact the cardiac nurse to have a look, because it was same way, you know, this coving all over. Can you see it?
Yes.
And even the EVR was coved up, and I have given them last session about EVR, ST segment elevation, which is something new, they didn't know before, and it is now coming up. And he thought he had something, and he was trying to discuss. In between, I saw it. I told him the digital effect, and he went to the
Talkspace.
what's it?
Talkspace.
The system, you know.
Yeah.
You get the GP notes, and they found
Okay.
digitalis as one of the
Okay.
of the medication. It is not a sign of digitalis toxicity.
Oh, is it?
No, it is digitalis effect. If he is in digitalis, he will have it. Doesn't give me any information about it having toxicity or not. No, it is only anyone on digitalis could develop these changes. So it is like a depression with coving. Can you see it?
Yes.
He bought even some ball inside, a ball, you know. This is how it looks like. How it looks like. It is digitalis effect. Like curved one. And here is the depression of tachycardia. Depression is there because of the demand, but the ST is going up. You see the difference? So it's depressed, but going up. In the ischemia, it was depressed, but going down. There's a big difference between both of them. So going up. Depression, but going up. So it is not an ischemia, it is just a demand due to the rapid heart rate or whatever. So another cause of ST depression could be the left ventricular strain pattern, and usually a patient with hypertension who is going to compensate the overload or the load after the heart, and they try to hypertrophy or try to compensate that. Initially he will be in strain because he's pushing against resistance, and what we get is ST depression with T-wave inversion. But the characteristic here to differentiate it, it is in lateral leads. Usually you are looking to lateral leads about the strain pattern. So lead 1, EVL, and 5 and 6. Another criteria you need to know about is the shape of T-wave inversion. It is like obtuse angle first limb and acute angle the second one. Can you see how it looks?
Yeah.
So it's going slowly down like an obtuse and it goes up acutely. So the two limbs are not equal in length and not the same pattern how they go and they come up. So it is not an ischemic T-wave inversion. You can see that, how it's going down and how it's going up. So it is the left ventricular hypertrophy or strain pattern inversion. Okay.
The
Also,
voltage criteria would also show here left ventricular hypertrophy, isn't it?
yeah, I have covered it before, but let
Yeah.
me discuss it. Lots of criteria has discussed, but I will just start with a simple one. V1 or V2 S wave
Yes.
plus V5 or V6
Six
R
R
wave
wave.
more
Yes.
than 35 small square
Yes.
or 7 big squares. So if you can define here, you can count here.
Yeah.
So it is about 1, 2, 3, 4. We can tell 5 all. And in V6, 1, 2, almost 3, so 8 big square. And here if we added them, that one will be more than 35. AVL more than 11 small square.
Yes.
So 1 and 2, they are 10 small square, and absolutely I have more than 11. These are other criteria. Lots of criteria I have discussed before.
Yeah.
This is very quick and simple criteria you can have. Is that okay? Noise discrimination. Sometimes we find an depression and elevation, but they're not specific. For example, when I discussed an ST segment elevation, we discussed about one small square in limb leads and two small square in pericardial leads, and depression, one small square depression or equal is defined as an ischemia. But if you find that the depression is less than one small square, or elevation less than one small square, so we cannot diagnose MI, we cannot diagnose ischemia, but we call it a non-specific ECG changes. Just we can put in the background, we need to maybe repeat the ECG, compare with the old one to see why it is like that. But usually it's not specific for diagnosis. It could be with or without T of inversion, and commonly associated with low, flat, slight inverted T wave. So we cannot diagnose. I didn't give an example for that because the important is to get the specific one, and the other non-specific is non-specific. Okay. Till that, do you have any question? We have discussed left bundle with ST segment elevation, how we can define MI in presence of left bundle. The first point is new left bundle is MI and proven otherwise. Even I don't look at Sgarbosa criteria. If new is new for me, but if it's an old one, then you can apply Sgarbosa criteria to see if he has an MI on top of left bundle. And we have covered the ST depression, which is simple, and non-specific ST segment depression. Any question to that level?
Can we go to the first slide again, please?
First slide. Is there, yeah, the criteria I put in the first, you mean my name?
The LPB.
I believe the first slide was just an introduction about the non-specific tools they have to use before initiating specific criteria.
Specific criteria.
So I was not actually intended to discuss it. Just to tell you there was before some non-specific. Yeah, is that one?
Yes.
Yeah, it's that one. Yeah, the Q wave in lateral leads is not supposed to be there in left bundle, but if it is there, it gives us a clue about anterior infarction.
Okay.
A reversal of R wave progression in the right mid-pericardial bleed with V1 and V2, V3, V4. Usually it is very small, but if it is high and reversal, it means going small by time. R wave in V1 and V2 that decrease in amplitude in V2 and V3 may indicate anterior infarction, but false positive diagnosis is common. That's why this criteria is a bit vague and non-specific. So they came up with more specific criteria, which is Sgarbosa criteria.
Okay.
And in fact, they came up with other criteria, as I told you earlier, but later on.
Okay.
Is it okay?
Yeah, that's all right.
Okay, good.
Okay.
So, I think I have finished that session, if I'm not mistaken. Any question anymore? That's fine, all?
Yeah.
Good, okay. So let me sure if I wrote something more before going to the next session. Yes. Yeah, nothing more. Yeah. Just thank you. Okay. Okay. So I'm going to stop here. I'm going to start another one. Continuing on. Thank you.
Continue.